Thanks to everybody for being here. I'm a cardiac surgeon from Adelaide, and we've got a unique experience in that we serve the population of the Northern Territory, and we see a large number of rheumatic valves coming out of the Indigenous population, which I think the rheumatic pathology in this group in itself, as I'll take you through, I think is also unique to the rheumatic disease internationally. A few disclosures, but nothing relevant. So I've actually got some incidence and prevalence data as well. So, rheumatic heart disease, as I'm sure we all know, is a disease of low socioeconomic communities. There are millions of people worldwide affected by it. It's fortunately now rare in most developed countries, except for what is predominantly Indigenous populations. There's a number of factors that influence, including economic, geographic, educational and cultural factors, that all together combine for poorer living conditions, reduced access to services and reduced awareness of the underlying disease. The disease profile has both an acute phase and a chronic phase. So the acute rheumatic fever, secondary to autoimmune response to group A strep infection, which is, as you know, quite common in the pictures we see of the Aboriginal kids running around the community with their snotty nose and bare feet, is I think part of what the problem we have here. It's poorly recognised, it's underdiagnosed, it has multi-organ effects outside of the heart to the rheumatic type areas, and the recurrence rates are unfortunately quite high, and there's reasonable evidence that repeated exposure and the increased has an increased incidence of heart valve damage, which I think also plays out in our particular group. In Australia, it's essentially a disease of the Indigenous population. There's a small percentage of immigrants and the elderly, which is actually increasing as migration increases. There's been a number of different series, but there's some good work that shows that about 6.5 per 1,000 of Indigenous Australians are affected by rheumatic heart disease, which is about 25 times greater than the non-Indigenous group. And one of the more disappointing numbers is Bo Remini, who's now based in Darwin, has done an echocardiographic screening of children, and there's echo evidence of rheumatic disease in 8.6 per 1,000 Aboriginal children in Australia, which doesn't sound that high, but if you put that into a world context, that's higher than the incidence in sub-Saharan Africa. So we're not doing well. Over time, 2010, 2.6% of the population in Australia was Indigenous, but there's significant regional variation, and about 30% of the population in the Northern Territory are Indigenous. They tend to be a younger demographic, and less than 15 years of age, 35% of the Indigenous community, or it's only 19% of the non-Indigenous community. And equally at the upper end, due to the other disease comorbidities they have and the early death that happens in the Aboriginal group, only 3% are represented over the age of 65, as opposed to 14% of the non-Indigenous population. We can see on this data from Australian Institute of Health and Welfare that both the first episode, majority occur below the age of 15, but there's also a significant number of recurrent episodes in this age group as well, and they obviously decrease with age. There's also a burden of disease in females rather than males. You can see here females in pink, males in blue, and again under the age of 15, but more females than males. When we compare the difference between the Indigenous and the non-Indigenous populations in Australia, we can see here by the different age groups, but sort of under the age of 45, even under the age of 65, in pink, it's purely the Indigenous group in this country. And there's a small number of the blue non-Indigenous coming through, predominantly in the over 65s, which represents that migrant group potentially. This basically just shows the number of cases per 1,000 as well. Again, male, female, same colourings. And again, the difference across the different age groups still shows that there's a burden of disease on the female side, and it's about twice that of the males. I'll just quickly go to the last one here, but the last slide here I think is important, is that the deaths per 100,000 of population, and we can see again in the pink that under the age of 65, there's a lot of death from rheumatic heart disease in the Indigenous group compared to the non-Indigenous. With the introduction of registry, surveillance and prevention measures, there has been, since the late 70s through to the late 90s, a reduction in the death rate, almost halving of it. but really since the early 2000s to the late 2010 window, there's really been no change, and it's been a fairly steady and stable rate of both incidence and also death. So in summary, the rheumatic heart disease in Australia is an Indigenous group. They're younger, they're female. There's an incidence of acute rheumatic fever, which is stable. The prevalence of rheumatic heart disease is now stable. That's obviously the influence of registry and surveillance work. The death rate's reducing, that's also stable, but unfortunately we're not at the point where we need to be, and we've got a lot of work to do. From a point of view of management, well, clearly there's a number of ways to go about this. Prevention is the best way, and while we do our best, and there are lots of measures in place to do this, there has been some impact made, but still there's a lot of work to do. The secondary measures, including the surveillance, the registries, and the secondary prevention measures are all also having an impact, but again, we still have a significant burden of disease, and unfortunately too many people get through to the, here we go, third stage or end-stage management of valvular disease, which is surgery, which should be and should remain a distant third, and unfortunately that's not at this stage happening, but we still need to aim that if people don't get to need surgery, then these two things are actually working. Surgical management, well, there's a number of options, and we've just seen balloon mitral valvuloplasty. That's clearly taken over from surgical valvotomy, and it's interesting that it was developed by a surgeon who's put the rest of his colleagues out of a job, so I'm sure he'll be not overly popular with the surgical community, but if you want something designed well, it's good that a surgeon was involved, so it's good news. The other end stage of surgery is really replacement or repair, which is something we're trying to do in this particular group, and I've got some data at the end about what we're doing there. And then it's the management of the concomitant disease, multiple valve problems, and incidence of coronary artery disease that influences what can or cannot be done from a surgical point of view in some patients. As to how you manage and what surgical options are done, type of valve, type of procedure, there are a number of factors that influence the decision making. Age of the patient and the sex of the patient, particularly in the female group where pregnancy, and in the young male group, contact sport is a big part of the cultural community within the most remote centres in the Northern Territory. Geography, their ability to access care, their ability to access special care and ongoing imaging follow-up, and being able to get to a surgical centre, and then their compliance with not just medication but also with follow-up and prevention measures that have got there's a significant burden of cultural and education issues that actually mean that there is a lack of understanding of the benefits of prevention measures that is well ingrained in the Aboriginal culture. So what are we doing? Well, there's some Institute of Health and Welfare data that from the late 90s to into 2012 that shows, and this is a snapshot over a 2-year window, that says there were 2,000 heart valve procedures done in Australia for rheumatic heart disease. I think these numbers are slightly inflated, and I'll show some Surgical Society database numbers, which are a little different in a minute. But of interest from these is that about 30% are mitral valve, 27% are aortic valve, and about 11% of these patients actually have mitral valve repairs done. Now, this is all comers and not just the Indigenous group. So about 40.5% of the workload is mitral. I think the reason some of those numbers are inflated is I suspect that multiple valve procedures have been counted as 2 rather than 1. The Indigenous group particularly, when you look, it says over the same time frame that there are 100 mitral valve replacements and 37 mitral valve repairs, so there is some work in this area and some people trying to actually repair the mitral valves. The ANZSCTS Database, over a 12-year window, there's 62,000 cases, and I must say, I must thank Anne Russell and Prof Maguire, and this is part of Anne's ongoing work, which she's allowed us to be part of, which is a great thanks to her. But so 17,000 valve cases, of which 1,300 are defined as being rheumatic by the surgeon at the time of procedure, which is 8% of the total workload. Of that group, 12.5% or 170 cases are are Indigenous. In this particular group, there's a few numbers that I think are of interest to us. And the first is the rheumatic patients, and the average age is a good 10 years younger than the non-rheumatic group. They're almost double the number of females in this group. and there's about 12% that are Indigenous origin versus only 1% in the non-rheumatic group. And 20% of them have had a previous balloon valvuloplasty. If we look at the Indigenous patients specifically, the mean age is 37 rather than 65. The type of valve implanted, and you can see mechanical valve in this line, tissue valves and mitral valve repairs. And if we look across the lines, we can see that despite them being almost half the age of the non-Indigenous group, there's less mechanical valves being implanted in the Indigenous group. There's a slightly increased number of tissue valves being implanted, and about 20% are getting a valve repair. When you look down at all the procedures that were done, 23 were isolated aortic valve surgery, and 75% of cases involved mitral, of which only 40% of them were isolated mitral valve cases. The others were either double valve, triple valve, or included coronaries. And that's an important number because I suspect that, or in my practice anyway, the isolated mitral valve disease is where you are more willing to repair, knowing that you may not have a long-term outcome, but you're not going to have a more difficult operation the second time around. So some of the data that we've had over about a 10 to 15 year out of our unit, firstly here, a broad stroke looking at Indigenous outcomes over a 5-year window. And they were 20 years younger, vastly more valve replacements, and they had 2.5% mortality overall, all comers, coronaries, valves, all sorts of surgery, versus 1.3% in the non-Indigenous group. So despite being younger, the acute outcomes are worse. If you look under the age of 55, the Indigenous group have a mortality of 3.3% versus 0.4% in the non-Indigenous group. When you look at survival, 1-year survival is 94% versus 96, 5-year 80 versus 87. And in the valve group specifically, we can see that at 1 year, it's 5% difference, and at 10 years, that the sum of that actually, sorry, at 5 years, some of that difference removes, which I think is due to the age of the non-Indigenous patients. If you look at just the rheumatic patients in isolation, we had over 800 cases, and of Northern Territory cases, 400 and plus of them Indigenous, again, considerably younger age group than the non-Indigenous patients, and the 30-day mortality was 2.1 versus 1.2% despite being younger, which reflects the burden of other comorbidities. And I'll just put this in as well, because this is, we looked at our coronary artery grafting in the Indigenous group versus non-Indigenous, and to our surprise, we were happy in a way that we actually showed that we could deliver a very similar level of outcomes for mortality at 30 days for the Indigenous and the non-Indigenous. So what this is telling us is that there's actually an increased burden that results in early death and perioperative difficulties and death in the rheumatic group that actually are different to the isolated coronary group. So the rheumatic valves are carrying a significant problem for the Indigenous patients we see. So are we doing the right thing, and should we repair more of these valves? Well, what do we know? We know the Indigenous Australians present younger. There's actually, I believe, increased fibrosis and fusion in the valves compared to rheumatic valves I've seen elsewhere. There's a significant loss of leaflet height, and more stenotic lesions, and there's good evidence that the more stenosis versus regurgitation is less likely repairable. Are the Indigenous patients different? I think they are. I think it's a more aggressive disease pattern that we're seeing. I don't know whether there's a genetic underlying precursor that makes them more susceptible to the rheumatic disease processes, and I think it's the ongoing and repeated exposure which is likely to be part of that as well. So we've probably all seen this slide ad nauseum over the years, but essentially the 3 different Carpentier classifications with normal leaflet motion, excess leaflet motion with flail segments and similar, and then where we fit here with the rheumatic disease in the restricted leaflet motion. So what's the pathophysiology? Well, mitral valve particularly, we see leaflet thickening and shortening with loss of height and loss of volume of the leaflets. The chordae are thickened in fusion. There is reports of elongation. They tend to, in my case, be thickened and maybe ruptured. annular dilation is reported, and the ones we see, it's not so much dilation, it's more that it actually changes to become more circular in shape. So the loss of the actual annular morphology is, I think, partly causal in what we see, and may actually be part of the reason for the regurgitation as much as the stenosis. And then there's the underlying LV dysfunction, which is clearly related to the valvular disease, but there's also an ongoing burden of the myocarditis depending on the repeated exposure from the acute process, and the commissural fusion, which actually contributes to the stenotic lesions. There are a number of different techniques reported for repairing rheumatic mitral valves, and these are some diagrams out of Carpentier's book. Basically, you have to correct the restriction and the shortening of the posterior mitral leaflet. You often have anterior leaflet pseudoprolapse. In other words, the way that the posterior leaflet is retracted down makes it appear as if the anterior leaflet's prolapsing, but it's usually well below the coaptation line and the line of the point of coaptation and the line of the annulus, so it's not actually a flail, it's just that there's no posterior leaflet for it to coapt against. What can be done is you can detach the posterior leaflet from commissure to commissure around the annulus, divide the secondary cords underneath here, which frees up the leaflet and allows it to move anteriorly to present the native leaflet for coaptation. You can then sew a patch into the posterior leaflet, and what this allows is that the residual posterior leaflet, the native posterior leaflet, basically then obtains more vertical plane in a more anterior position and allows the anterior leaflet to coapt against it and creates a more normal position and corrects for the lack of coaptation. Annuloplasty to recorrect the annular shape, and you can see in this picture, interestingly, it's actually drawn very circular to how it should be with the annuloplasty in place in that more sort of traditional saddle shape. Can also do anterior mitral leaflet advancements. I must say in my hands I've had not a lot of success with this being a good outcome, but basically detaching the anterior leaflet and sewing a patch in there to allow the anterior leaflet to shift more posteriorly. We have much greater success with shifting the posterior leaflet anteriorly, but we have had cases where we've had to do both. So our approach, basically first thing we do is bilateral commissurotomies. There are some patients and some reports internationally, mostly out of Sampath Kumar's group out of India, who talks about peeling the fibrous layer off of the anterior leaflet, which then allows the anterior leaflet more mobility. I've tried, and I've tried really hard, and I've had about 2 successes of being able to do this, but I watch his videos and he gets this nice little plane and it lifts off and it just comes off with a bit of sort of gentle playing with the forceps. But in the Aboriginal patients that we see, there is no plane, and I just cannot get it to come off. And I don't know whether that does go back to what I said about the increased burden of disease and the type of disease process and the amount of fibrosis that's there, but we've had very little success for that. And the ones that we have had success with, it does actually allow the anterior leaflet to dome more towards the atrium, but the problem is that you still actually have quite a lot of thickening along the free edge of the anterior leaflet, and as such you haven't really gained a lot with regards to where the anterior leaflet reaches across the opening of the valve. So we detach the posterior leaflet completely. We divide the secondary cord, which allows the free edge of the posterior leaflet to move anteriorly, and we sew in a patch which is usually between sort of 1 to 1.5 centimetres at a minimum through the midpoint of P2. The Indigenous patients clearly have greater mortality risk, seems to have poorer long-term survival, and the question is, are we doing the right thing and should we be repairing more valves? Problem is that not all valves are repairable. The leaflet volume, the length, the commissural disease, the timing of the surgery, and how we actually decide to manage, because these patients are coming back if we don't repair it and placing a tissue valve. Because the problem we've got is managing durability and functionality and managing the other valve pathology that is there, often in patients that are 17-year-old females who won't take warfarin, can't take warfarin, aren't able to access follow-up for warfarin, or a young guy who wants to continue playing football and won't take his warfarin for those reasons. So if you don't repair these valves, we end up putting tissue valves in, and we're seeing those patients come back between 5 and 7 years. I'll fly through this. Are you okay for time? Okay. So just very quickly, some of the highlight the issue we've got. So we've got a 17-year-old female who wants children, lives in a remote community, is poorly compliant with both clinic attendance and medications. Warfarin's not appropriate. Severe MR, she's got moderate aortic regurgitation as well, dilated ventricle, but with a normal ejection fraction. Clearly, she's got thickening and reduced mobility of the anterior leaflet and much greater thickening and restriction of the posterior leaflet, a coaptation defect, and it's got significant mitral regurgitation. So we did the procedure we described, so we've actually got a thinned anterior leaflet that's actually coapting. We've got a verticalised posterior leaflet and there's no MR. But as some of you have already picked up, there's still an ongoing coaptation defect with the aortic valve, and there's a reasonable, moderate at least, aortic regurgitation. So the dilemma was, do we do something to a mitral aortic valve as well, or do we leave her alone? We'll know that she's coming back for a mitral at some point, and we'll deal with both valves when she comes back the next time. We decided to do that, and at 15 months, the echo at this point shows that the aortic regurgitation had not progressed significantly. The central defect still remained. And she's still going, about 9 years since her surgery. Sorry, 2010 I think I did her. So she hasn't come back at this stage and still doing well. This one is of interest because the disease is actually greater. There's thickening of the leaflet and greater coaptation failure. The question was whether we should do the procedure or not. With regards to repairing the valve or just replace it, we did repair the valve and got what appears to be a reasonable result in that it's not an adequate length of anterior leaflet. We didn't have enough to work with. We had trivial MR afterwards with a reasonable result from that point of view. But my concerns with this, and there's a comparison here between the two, is that if we just look at the volume of coaptation that we got with the first case versus the volume of coaptation that we have here, is that this, as our concern was that she'll be back with an early failure. At this stage that hasn't happened, but she certainly does have some MR at this stage and she's being followed closely. She's got moderate at least MR at the moment, 7 years down the track. So our experience, well, basically we've had 231 cases, 65 repairs in a young age group, and our mortality overall 2.5%. In the repair group it was 1.5, and 10 of those patients had combined AVRs. If we compare that to our valve replacement group, the mortality is half. For some reason, there's a much greater mortality in both the mechanical and the tissue valve group, and the tissue greater than the mechanical compared to the repairs. Probably reflecting a greater burden of disease and the less ability to be able to repair the valve. 65 of the cases, or 64 of them were Indigenous. There's 1 early death, 3 late deaths. 3 of them are lost to follow-up. 11 of them have had reoperation and surgery at an average of 55 months. We've had echo follow-up on this group of patients out to a mean of just under 4 years. At that stage, 60% of them have got mild or less MR, and 75% of them have got less than mean gradient of 8. And at that stage, 75% of them are free from reoperation or death at 77 months. So we believe that mitral valve repairs have lower risk. We know that they'll need further surgery. We think the durability is better than a tissue prosthesis. Certainly the reoperation is easier when we come back, and we have to balance in the management of other valves at the time of both the initial surgery but also what we know we'll be back for in the future. Thank you.